first time in the snow, you are going to give the microphone to an anesthetic. That's possible. Sorry? Anesthesiologist. Ah oui, j'ai dit anesthetics, n'importe quoi. Anesthesiologist. So you are going to sleep a little bit before lunch. So we thought that it was really, really important to have, you know, the perception of how to manage all these patients who are obviously very, very complicated, and maybe with several surgery, from very light surgery to very severe surgery. And I think the anesthesiologists have to say how they think about, you know, the management of this kind of patient. And Chawki is one of our, I don't know, best anesthesiologists in our department, and he has always new ideas, and that's why we wanted him to present how his reflection for today.
Thank you, François, for the presentation. I'm happy and glad today to present you new thoughts on sedation modalities for neuro-orthopedic surgical procedures. Before starting, I would like to clarify that the subject of the conference will concern the management of acquired deforming hypotonia, where a new anesthetic protocol has been developed. For the other neuro-orthopedic procedures, like osteoma resection, arthrodesis, the procedure remains standard. I would like to remind you that acquired deforming hypotonia affects a population elderly and handicapped, leading to a significant risk of multiple osteoarticular deformities due to muscle contractures and have a functional impact. Traditional surgical treatment has proven to be effective but cumbersome. It concerns a patient with advanced age, multiple pathologies, and impaired autonomy. A new technique of percutaneous sternotomy, as you know, with the needle, has been developed at Raymond Poincaré Hospital by the Normandy team, and has demonstrated its effectiveness and good tolerance. This procedure is short, not very painful, and reduces the destabilization of sometimes very precarious medical situation. This technique has been validated with good efficacy and few side effects by studies on cadavers and on living patients. So this kind of intervention in such special patients represents a challenge for the anesthesiologist. We are in front of a scale. This is the anesthesiologist. On the one hand, we have a vulnerable patient who is aged, with multiple pathologies, autonomy loss dependent. And on the other hand, general anesthesia in this case is not devoid of risks. We can have to face arterial hypertension, inhalation, respiratory depression, nausea, vomiting, and the worsening of cognitive impairment. The role of the anesthesiologist is to provide an intervention with little or no pain and a fast recovery. So this is what led us to set up a new anesthesia protocol. It is resumed in 3 items: myopia, face mask with administration of 50% mixture of oxygen and nitrous oxide, called myopia, and titration intravenous of midazolam and ketamine. This anesthetic protocol uses ketamine in combination with midazolam to achieve a light anesthesia. The aim is to preserve the spontaneous ventilation, to avoid the orotracheal intubation, and to shorten the duration of anesthesia. It also allows loss of consciousness, protection of the upper airways, and hemodynamic stability in this fragile patient. Here, a patient is installed in the operating room with standard monitoring, a face mask with MyoPA, and the start of titration of midazolam and ketamine. Disinfection of the leg to be operated on is done, and the surgeons are ready to operate. In addition, we can do also an additional anesthesia if needed with morphine, sulfentanyl, hypnotic, propofol, and local anesthetic lidocaine made by the surgeon. If the ventilation is difficult, we can use alternatives like jaw subluxation maneuver, insert Guedel cannula, perform manual ventilation or intubate and ventilate this patient if this fails. Here we see the subluxation of the jaws, freeze the upper airways and preserve the ventilations of the patient ventilation. Sorry. And this maneuver is carried out frequently. It's simple, often necessary, and to be done with, by a qualified personnel. Now let's talk a bit about MyoPA. It has analgesic characteristics. It provides conscious sedation. Cough reflex is preserved. It has short duration of action. Peak analgesia is achieved between 3 to 5 minutes. It effect disappear between 3 to 5 minutes when stopping. It is effective in 80% of cases. And finally, the administration shouldn't exceed 1 hour. Now, we will focus on ketamine that from a pharmacological point of view presents a very interesting qualities that is very useful in neuro-orthopedic surgery. Ketamine is lipophilic drug that binds poorly to plasma protein. It has a large volume of distribution. Its action is fast and its half-life is short. It has a liver metabolism and its accumulation in fat. It's common in prolonged use. It is active by almost all routes. Now we are going to have a look for pharmacodynamic characteristics. Ketamine has not only a sedative and anesthetic effect. However, it has many other pharmacological qualities. First, this anesthesia allows the maintenance of hemodynamic constants, even in circumstances of shock, what we call the sympathomimetic effect. Spontaneous breathing and is maintained, and laryngeal reflexes are preserved. It has also a bronchodilator effect. Second and important characteristic of this product, but which is less favorable, ketamine induces psychodysphoric manifestations ranging from simple cognitive or memory disorder to episodes of depersonalization in an otherwise completely normal subject. Now we move to 2018 American guidelines to ketamine use in acute pain that summarize the relative contraindication. Ketamine should be avoided in case of poorly controlled cardiovascular disease, in pregnancy, in case of active psychosis, in severe hepatic dysfunction, in elevated intracranial pressure and elevate intraocular pressure, and the use must be done under supervising of experienced physician with ketamine, like anesthesiologist or critical care physician. Let's take a look at one of the major effects of ketamine delirium. Ketamine is psychedelic, provides a very marked visual and auditory hallucinations and visual hallucinations, and the feeling of dissociation between body and mind, feeling of decorporation, seeing oneself. It affects senses, judgment, and motor coordination. May causes also nightmares or near-death experiences. Hallucination can be experienced as traumatic by the patient. In this case, the use of benzodiazepine, such midazolam, is beneficial. Here we see a kind of visual hallucination that we can experience by the patient. We can prevent this delirium with a serene atmosphere, and this psychedelic experience can be accompanied by caregivers and positively oriented by positive suggestion. And as we saw above, there are very beneficial use of midazolam and benzodiazepine. We can see here an example of positive suggestion by speaking slowly and orienting the patient directly and calmly. Now, other effects of ketamine, the effect on cognition. Ketamine has neuroprotective and decrease in neuroinflammation effects. Here, a study made in 2009 that demonstrated ketamine attenuates the post-operative delirium and have an anti-inflammatory effect. Ketamine has many other interesting effects. This study made by Maki in 2008 shows that intraoperative use of ketamine for surgery in military operations decreases the prevalence of post-traumatic stress disorder. Last and important effect of ketamine and depression. There are many studies that demonstrated the effectiveness of ketamine in severe depression. To summarize, these are the benefits of ketamine. On short term, hemodynamic stability, maintenance of spontaneous ventilation, very interesting for us anesthesiologists, antinociceptive effect. On long term, on cognition, neuroprotective effect, antidepressant effect, anti-hyperalgesic effect, interest in chronic pain, decrease in neuroinflammation, and prevention of post-traumatic stress. So we conduct a monocentric prospective observational study at Raymond Poincaré Hospital. The protocol consists on administration of the MIOP, 50% of nitrous oxide and oxygen by face mask, and titration with midazolam and ketamine until loss of contact. We included 121 patients of 1 year. Average age was 55. And both sexes were equitably represented. As we move to results, the average dose of used of ketamine was 60 milligrams and midazolam 1.5 milligrams. The satisfaction was good. Evaluate with a scale from 0, good, to 10 bed with a mean of 2 points for the anesthesia team and 1.93 for the surgery team. The short duration of surgery, a mean of 60 minutes. Pain was low in the recovery room. A mean visual analog scale was 0.86 on arrival and on discharge, and also Algo Plus was lower. And the important result that for patients, only communicating patients, the memory was positive in 70% of cases, negative on 2% of cases, and neutral on 28% of cases. And for intraoperative complications, essentially minor respiratory, recurs to subluxation, Guidal cannula, manual ventilation, and exceptionally one major complication with one intubation of patient. As a conclusion of the study, this protocol works in 2/3 of the patient, often when the cognitive disorders are important. In the other case, we must deepen the anesthesia with propofol and sulfentanyl. We have to note it isn't without risks and complications, and it must be performed in a regularly and secure environment of the operating room with experienced anesthetic and surgical teams. I conclude with the key message. There is almost no data concerning anesthesia and acquired deforming hypotonia. The implementation of this simplified anesthetic protocol has allowed our PRM and surgical colleagues to recruit more patients. These patients were considered non-operable because they were too medically fragile. Ketamine, with its various interesting properties, represents the anesthetic molecule of choice for this patient. The GACH anesthesia team has a safe and very attractive protocol. Thank you.
Bravo. Thank you, Chawki. So even the anesthesiology, it has a huge impact, on the management for our patient, and it's a real proof that you have presented to us. So do you have any question for Chawki? Yes, there's a lot, you see.
Thank you, François. Thank you for your presentation. It's really very, very interesting. I'm talking about our experience in Montpellier and using this kind of protocol for patients for percutaneous needle tenotomy. So we used, at the beginning of this activity, we used to use ketamine propofol protocol, but the loss of control means no nociceptive effect. So for the lengthening tenotomy for the Achilles tendon, it's very annoying because triple reflex, triple flexion at the moment of the puncture of skin. It's very, very embarrassing. So since a few months, we started to associate this systematically. Remifentanil, which has a very brief, very short delay of action, and we think it's very, very interesting. Almost in the patients with cardiovascular problem, age patients. So we started associated ketamine, propofol, and remifentanil. And after the procedure, when the patient can quit the operating room, we injected lidocaine at the point of the tenotomy for the analgesia at the moment of cast. So sorry, you understand? Okay, serial casting. So this is our protocol, but I'm very, very glad to see that we do something
If I understand well, the problem is the movement of patient at the beginning of surgery. We faced this problem also, and we work together with our surgeons, and we began very slowly the surgery. We ask them to test first and to see how is the patient reaction. If it's possible, we can maintain a little bit patient, the leg or the hand of patient in order to do the surgery. Our items to judge if the patient is comfortable or not, the heart rate, the arterial tension, and the mimic, the face. As I say, it works perhaps in 66% of cases. We are, if we feel that the patient isn't comfortable, we add subfentanyl and the propofol. But here, the problem is we can face often kind of depression, respiratory depression. We know that they are very fragile patients with a very morbidity, like and cardiovascular disease. Like it's a very progressive protocol. It needs both straight cooperation between surgeon and anesthesiologist.
I have two rapid questions. First question is about the population of your study about acquired deforming hypertonia, and I saw that there is an average age of 55 years old, and I'm wondering if for the geriatric population, very old patients, you use lower dose or with the strict titration is the same? And the second question is about if you use virtual reality, because you spoke about a positive environment in the surgical room, and if you use this kind of technique, and if it allowed to use low dose of anesthetic medics.
For the first questions, our population is very varied. Not only geriatric patients, we have also medullary younger and sicker of trauma. That's why the average of age was lower than geriatric population. In the second, the second question, we don't use virtual mask, or it's only with keep contact and speaking to patient if possible, because some of patients have very heavy cognitive disorders, and communication it's not possible at all cases.
I was going to comment on your point about the reflex pull of the limb. And we see that even when we do botulinum toxin injections. And so what we do is we use a cooling spray on the skin right before the pinprick, and that reduces that significantly.
Merci beaucoup, c'est le bonheur de travailler avec des anesthésistes comme toi. Je voulais faire une remarque parce que sur le problème de la douleur, ce qui me frappe, c'est pas les ténotomies qui font mal. C'est-à-dire qu'on gère bien l'anesthésie locale et allongée, coupée. C'est notamment le claquage du tendon quand on fait des ténotomies simples. Je trouve que, et donc ça pose le problème effectivement des protocoles qu'on en a. Peut-être qu'on peut les soulager parce que je pense qu'on en fera de plus en plus directement dans les établissements, dans la notion du aller vers. Mais je ne sais pas comment gérer demain cette douleur très spécifique quand vous coupez un ischio-jambier. Au moment où le semi-tendineux remonte, on sent que c'est là qu'on fait mal. Et donc, ça va être quoi les protocoles d'accompagnement de ce type de douleur? Je ne trouve pas que c'est le tendon proprement dit qui fasse mal. C'est au moment où au moment où il y a cet allongement.
I think that the patient population are very varied. They are, and it depends on personal historical of pain. If the patient have chronic or neuropathic pain, the management must be adapted to this patient. But at this moment, we haven't specified protocol for this kind of pain.
Yes, I have two rapid questions. You said that nearly 40% of the patients need some sufentanil and propofol. Did you identify some characteristics of these patients? And do you have a rough idea of the proportion of patients who wouldn't have their procedure if general anesthesia was the only option?
For the first question, we have an idea with the patient that the protocol does work. Generally, it's elderly patient with cognitive marked disorders, and if the functional cognitive functional are intact or not very marked, we know I think at that advance that the protocol won't work with this kind of patient. For the excuse me, for the second question.
Do you have an idea of the proportion of the patient who wouldn't have had their surgery if you couldn't do this light sedation? If you had only general anesthesia at your disposal, how many patients wouldn't have had their surgery?
I don't have a statistic of this kind of patient, but we can discuss case by case in function of the pathologies, the cardiovascular respiratory state of patient, and we can also propose other treatments if we evaluate that general anesthesia will be very dangerous for this patient.
Okay, I think. Allez, one last question, and after Romain David.
Ouais, ma question, c'était de savoir pour certains patients, notamment les patients paralysie cérébrale, qui bavent, hein, qui ont un bavage important. Les patients sont souvent installés sur le dos. Je sais que nous, quand on leur fait du méopa, on a des problèmes parce que la salive s'accumule dans le masque. Comment vous gérez les choses?
In some cases, we can use atropine. That is very interesting in this case. But your suggestion is very pertinent because this is a factor of inhalation for this patient who they haven't a very effective cough reflex.
So thank you so much, Chawki, for this presentation. Now, so we are going to change a little bit our mind about the scientific program because as we have time a little bit in the beginning of the afternoon, we are going to change and we are skipping Antoine Perrier, who is going to make his presentation in the beginning of the afternoon. And we ask to Romain David to come and to present intramuscular anesthesia block assessment of practice. So before talking about that and taking time, just because we don't understand why there is no, the...
Just here, I need translation.
Ah, okay, so I have an issue with my screen, if someone can come to help me. Because it is not the same on the screen of my laptops and on the screen. Jean-Michel, il y a quelqu'un qui peut m'aider, s'il te plaît?